There we go. Perfect. So we have like for tonight for our webinar, we have a full agenda. We're starting with introducing the program director panel and the residency moderators. We'll have a talk by Dr. Khaja about from the University of Michigan about the summary of the traditional DR/IR fellowship training pathway and the new IR residency. Then this is followed by a talk from Dr. Sabri from UVA dealing with an overview of transferring from DR to IR. Dr. Sabri will also a little bit discuss the ground rules with regard to the ACGME and what needs to be considered from that standpoint. And then we as moderators have prepared questions or topics we felt were very pertinent to the to switching from DR to IR and what needs to be considered, which will be interesting questions. And we'll have Dr. Walker from MGH, Dr. Khaja from the University of Michigan, Dr. Sabri from UVA answer those questions. It's like a series essentially, and then we'll have the audience submit some questions for the panel members, so they can then answer some of those questions. So the ground rules for tonight's webinars: we'll mute all but the panelists mics throughout the webinar just to minimize the background noise. For your questions towards the end, once we're coming towards the end of our prepared questions, you can type the questions into the chat box if you have some questions or comments. Everything that's discussed during the webinar will be recorded. If there's any part of the webinar that's inappropriate, irrelevant to discussion, it will be removed before we publish it online or we make the webinar available for the public. We would recommend to refrain from asking questions at the beginning, since part of it may be covered by the excellent talks and by the questions we've prepared, and then submit your questions towards the end of the prepared session via the provided comment box. Your questions will be only visible to the moderators, and then we, the moderators, specifically Akil, we'll do that. We'll then distribute the questions to our program director panel members. We have a fantastic panel member of 3 fantastic program directors who joined us for tonight. So now we come to the program director panel introduction. Our first panel member is Dr. Walker, who's an interventional radiologist at MGH in Boston, Massachusetts. He's an assistant professor of radiology at Harvard Medical School. He's the program director for both the interventional radiology integrated residency and the IR fellowship at MGH. Dr. Walker received his medical degree from the University of Arkansas. He did his general surgery internship at the University of Colorado Health Sciences. He did his diagnostic radiology residency at Tufts New England Medical Center in Boston. Did his vascular interventional radiology fellowship at Tufts New England Medical Center, Boston University Medical Center. He specialized in complex endovascular techniques for treatment of arterial and venous disease. He is well known with numerous research publications with primary focus on complex arterial and venous interventions, GI hemorrhage, advanced filter IVC retrieval, and peripheral arterial disease. He has authored a plethora of SIR committee guidelines for a variety of endovascular procedures. Our next panelist is Dr. Khaja from the University of Michigan. He's a vascular interventional radiologist in Ann Arbor, Michigan, affiliated with the University of Michigan's Health Centers and the VA Ann Arbor Healthcare System. He's an assistant professor in radiology at the University of Michigan. He's the IR residency program director and associate program director of the Diagnostic Radiology residency. Dr. Khaja received his medical degree in MBA from Indiana University School of Medicine, did his radiology residency and IR fellowship in the VAR clinical pathway at UVA. He specialized in aortic diseases, management of complex venous and peripheral artery disease, and his research focuses on endovascular management of aortic disease, specifically complex aortic pathologies like aortic dissection, aneurysms, and endoleak treatment, vascular complications of solid organ transplantation, complex venous disease, and management of complex venous disease. And our third panel speaker is Dr. Sabri from UVA. He's a vascular interventional radiologist in Charlottesville, Virginia. He's affiliated with the University of Virginia Medical Center. He's an associate professor at UVA. He's the program director for the radiology residency at UVA. Dr. Sabri received his medical degree from the University of Jordan Faculty of Medicine, did his radiology residency at the University of Iowa Hospitals and Clinics, did his vascular interventional radiology fellowship at the University of Virginia. He specialized in minimal invasive treatment of liver and kidney tumors, uterine fibroid embolization, thoracic and abdominal aortic disease, peripheral artery disease, varicose veins, venous interventions, dialysis access, hepatobiliary interventions, and GU interventions. He did research with a primary focus on endovascular therapy, resulting in a plethora of over 30 publications. And now I'm going to give the word to Alex, who's going to introduce the resident moderators.
Hi everyone, my name is Alex Joe, and I am the current chair of the IR Residency Training Committee and an R2 at University of Michigan. And I want to introduce you guys to Sasan and Akil, who helped create this webinar. And Andy is not listed on here, but Andy Niekamp from University of Houston is he's been monumental at helping plan all of these events. And this webinar is the last of 3 webinars that we had planned with the RFS and MSc. And the information that we got from these webinars have been really invaluable in helping medical students and residents understand the whole process and the changing training paradigm of IR. And the 2 previous webinars have been already recorded, and they're already available on RFS, and this one will be recorded and published as well. So our contact information is going to be shared at the end, so if you have any questions or concerns, just let us know. And thanks again, and I hope you guys enjoy the rest of the webinar.
Okay, so next we will have a summary of the traditional new training pathways by Dr. Khaja from the University of Michigan.
Great, thank you all for inviting all of us for this very important discussion. I wanted to just start off with this table that's available on the RFS website. This is a table that was put together by the RFS to simplify this somewhat complex but very simple breakdown of different training pathways. So you can see on this table here that we have the stage of residency and the different pathways. So we start off with the traditional pathway, and we'll go through each one briefly in a couple follow-up slides. So we start with the traditional pathway. This is the standard training that many of our forefathers in IR went through. It's a 1-year internship, be it general surgery, internal medicine, or transitional year based off of your interest, followed by 4 years of diagnostic radiology residency with variable exposure to IR depending on your program, your elective choices, and your experiences. There are mandatory IR rotations required for everybody who's doing diagnostic radiology to a certain degree. And people who are students who are residents rather, who are interested in IR usually gravitate towards performing and completing more IR rotations. You'll notice that there are no required, there are no required clinical rotations in this traditional pathway, nor are they generally set up. This is followed and completed by 1 year of an ACGME approved IR fellowship, which is PGY 6-year. This program, as Dr. Sabri will mention later on, ends on June 30th, 2020. So this traditional pathway ends at that time. The next option is the integrated IR residency, which is the new residency that has been approved, and there are, I believe, 61 programs at this time. This is an application directly from medical school. So medical students who are interested in IR would apply directly to this program. And it again starts out with 1 year of an ACGME approved clinical service. That depends on the program to which you're applying. Several programs have decided and recommended that surgery be a preliminary year, and in fact have set up a combined program. Other programs leave it open to the applicant as to whether they perform general medicine or transitional year. And this typically consists of a 1 year clinical followed by 3 years of diagnostic radiology, and then actually on the table, slightly incorrect, is 2 years of IR and IR-related clinical rotations. Those are not specified in the program requirements, but frequently programs have vascular surgery, medical and surgical oncology, transplant, cardiology, and some ICU. As required by the program requirements, you have to have 1 month of ICU experience during this PGY 2 through 6 timeframe. And there's flexibility per the program requirements as to when the clinical rotations occur, as well as when the IR rotations occur, and the IR-related clinical rotations. The next option is the independent IR residency, and this is without the ESIR, and we'll explain that on the next slide. This is similar to the current fellowship model, where you do 1 year of clinical, followed by followed by diagnostic radiology for 4 years, again with IR rotations as interspersed, and then actually completing a 6th and 7th year. So it would be a 2-year fellowship or 2-year senior years in IR, where you would complete all of those requirements that you've done in the integrated residency. The benefit for this is for those who are currently in residency or who aren't sure that they want to do IR, it gives them more time to finish their diagnostic radiology program and then move into a program that has an independent residency. That is actually a 7-year program unless you have ESIR. So that is early specialization in interventional radiology. Now this is a program for diagnostic radiology residents, where it allows you to have sort of a specialized track in IR, which you can declare earlier than the end of your residency, and complete some of those requirements for the IR residency in that time. This is more consistent with a 1-4-1 model rather than a 1-4-2 model. And it is very similar to the integrated IR residency, but it does have specific requirements. And those include 12 months of IR or IR-related rotations during your 4 years of DR residency, and 1 month in the ICU, which is very similar to the integrated IR residency. Keep in mind that this is an application to a diagnostic radiology program that has been approved for ESIR, and then the residents would continue into the independent IR residency at the end of their training. Many of these programs will have their clinical rotations near the end of their training, as the residents have declared that they want to convert to IR later.
Thanks a lot, Dr. Khaja, for that excellent overview of the different pathways. It was very, very helpful. Our next speaker is Dr. Sabri. He's going to give an overview of transferring from DR to IR, particularly pertinent and also considering the ACG rule, which are crucial to follow when considering transfers in different programs.
Yeah, thank you. So I just want to clarify something in the prior slides. The fellowships will end July 2020, so there will be no fellowships beyond July 2020. So the last class will be 2019 to 2020. So sort of make sure that's clear. Maybe some of the prior slides. Just make sure that it's clear that's not the last fellowship year starts July 2020, but ends July 2020. So that's a timeline that we know of. So when we talk about what's going to happen, for the current residents, and so we talked in the past about what's going to happen to the students and the application to the integrated. I think the focus here is what should the current residents do who are already in residencies, in VR residency. So the current PGY3s or R2s will be the last fellowship class, which is 2019-2020. The integrated IR residents through the upcoming IR match will be in their PGY4 in that year, 2020-21, and they'll be in PGY5 in 2021-2022. So they will not be, ready yet to function as what currently are the fellows, which are PGY6 or PGY7 potentially. So we will run into this issue where they're going to be what we call the two gap years. So these are the 2 years that there'll be no fellows, and then the integrated IR residents through this upcoming match would not be yet in the PGY6 level, except for some of the programs that filled last year, but for the majority of the programs, that'll be the case. So the way to fill these spots, this PGY6 and 7, is through internal transfer from the DR of the current interns and the PGY2s. So these are the ones who are going to fill this gap, are the current interns when they show up next year, and then the PGY2s. Or the other option is the programs will fill it through independent IR residency, which is going to function like the fellowship. Next slide. So what are the transfers? It can only happen for integrated IR programs. So it doesn't apply to independent because independent only accepts DR residency graduates. So you cannot transfer it into an independent. You have to be accepted. You have to go through it through the match. The residents may transfer from a DR residency to an integrated residency at their home institution, and that's something that I'm sure all of you are aware of, and I can't emphasize it enough that the only way this can transfer can happen is at the same institution. And then transfers from a DR residency at one institution to another one will not be allowed. I think that's very clear. And that's a message that the ACGME wanted to pass to this group so everyone is aware of it. Next. So to qualify to transfer at each level is the following. So if you are at PGY 3 and 4, I mean an R2 and 3, residents can transfer to the same level, equivalent level of their training in the DR program. So if you are a DR PGY 3, when you transfer to an IR PGY 3, and so on. So you transfer at the same level. The residents may transfer to the PGY 5 level, which is the R4, if they have completed 3 years of training and they're eligible to take the core exam. They may not take it at the end of the 3rd year, but they should be eligible, meaning fulfill everything they need to do it. And they have to have successfully completed 3 IR rotations. So if you want to transfer at that level, these are the requirements. Now, can you transfer the other way from IR to DR? The program requirements are not yet completed. They're still in draft form. So we expect it to be a very similar process. It's going to be at the same institution and at the same, they have to transfer at the same level of training, equivalent level of training. This has not been finalized yet. It's still in draft form, but we expect it to be the same, that the transfer is going to be at the same institution. Next. Just in terms of notification, things are important. Transfers have to be agreed upon by both PDs. It has to be a submission to the local GME to discuss that, and they have to approve the transfer. Then the American Board of Radiology needs to be notified that this person changed from one residency to another. And the ACGME needs to be notified through a system. It's called the ADS system, Accreditation Data System, but they don't need to get permission for that. Couple of points I would like to add here before we just jump into the questions. About the timing of transfer, it's preferable from RRC that the transfer from ACGME, that transfers happen at the beginning of academic year, meaning July 1st. It's not going to be encouraged to do transfers mid-year unless there's a reason for it. The second point is for the current interns who are going to show up for their residency in July, you cannot transfer immediately on the first day you show up. Basically, as part of match rules, you should work for at least 45 days at your new residency before you're allowed to transfer. If you're current intern, you have to show up at your residency, which is DR. You have to fulfill your DR, unless you match into integrated. If you match into a DR, you have to be there, work for at least 45 days, then transfer is requested. But as I said, RRC is not encouraging that transfer till the next July. So if you're a current intern, the transfer most likely is going to happen at the beginning of your second year of radiology, not the first year. So these are some, items I would like to wanted to discuss, bring up before we go into questions.
Dr. Sabri, thanks so much for the great presentation. I do think it's very important that we, during those transfers, really consider and follow the or adhere to the ACG rules. So thanks so much for explaining those to us and giving us that excellent presentation. Next, we're going to go to the questions we've prepared as moderators, which we thought maybe interesting to discuss with regard from switching from DR to IR. Our first question includes essentially two parts. The first part is a transfer from DR to an integrated IR residency currently possible at your institution, so for MGH, University of Michigan, and UVA? And if so, have you already had students, residents transfer, or do you plan on having transfers in the very near future, maybe during this or next academic year? This question will be answered in the following order. First, Dr. Walker from MGH, and Dr. Khaja from the University of Michigan, and then Dr. Sabri from UVA. Dr. Walker?
Yes, so thanks for including me as a panelist this evening. So yes, at Mass General Hospital, it will be possible to transfer. We haven't had that happen yet, and the reason for that is that at this point, everyone who's currently within the DR residency, this was their initial choice, was to enter into DR. We really have a few people who have begun to identify that IR is their area of interest, but many of them have expressed a similar interest in at least participating in the first several rotations within the various subspecialty areas of radiology to be absolutely certain before transferring into a purely IR sort of track. And one of the things I think that has been helpful for our institution is that we've had a pilot program for several years wherein we've mimicked the ESIR program in the fourth year, so a focused year that really does incorporate the IC rotation and also does allow for the multiple IR or IR-related rotations. And we found that very helpful in terms of people actually understanding kind of the career path that they've chosen, they've embarked on. So in order to kind of make this perhaps a more vibrant choice before that R4 year, at our institution, we're also beginning to institute for the R2s the option, or actually the arrangement whereby their first radiology rotation, although considered 2 blocks, will be a 2-month rotation on interventional radiology. So they will have in-depth exposure to the whole spectrum of IR, clinical longitudinal care, procedural care, inpatient rounds, so on and so forth, and actually have a really extended exposure to this, so that at that point, hopefully they're working with informed information about a transfer. So concerning those things, at present, we've not yet had any transfers because we'd like to have that sort of robust introduction before encouraging people who originally matched into DR solely to perhaps then consider an IR transfer.
Great. So I can continue. So at the University of Michigan, we have had several residents who have transferred, so it is possible. We've had 2 who are currently PGY5s, 1 who's a PGY4, and Alex who's a PGY3. As Dr. Sabri mentioned, it is best to do this at the transition point of a year. So we completed this on June 30th of this past year, so that these residents transferred in to the IR residency officially on July 1st. As Saher mentioned, there are some T's to cross and I's to dot, and so it does require notification of the local GME, the ABR, and the RRC, as well as involvement of both program directors who have reviewed the residents' performance as well as their milestones for the diagnostic residency program, as well, and then the new IR residency milestones. I think, as Dr. Walker mentioned, it's important to have had established having something established. We've had a VIR clinical pathway for a few years, and these residents who transferred were all a part of that, and they have established a vascular surgery rotation, ICU, hepatology, as well as cardiology and transplant surgery. So we have several different rotations and have easily been able to transition that. I think a lot of programs have done this in their own methods and will be ready for this transition in the near future.
Yeah, so I mean, I think most programs, as you heard, I mean, will be transfer will be available. I think it's an HME rule. Any program that follows the rules knows that they can transfer. The question is why to do the transfer and the need for doing it at this stage. We have not transferred anybody. We are not planning. We had a lot of discussions about it. We're not planning on doing it for this year or next year. So we're going to wait till the first class matches into the program. So there's going to be the upcoming match, and when that class starts their academic year, which is 2018, that's when we're going to transfer residents into the program, which, as I mentioned, the current interns and the current PGY2s are the ones we're going to transfer to fill in the gap years. To do any transfer before that, this is a personal opinion, I don't think it's necessary, because you can still do some, if you have it in place, you can still be in DR and do the same things that you were planning on doing in your IR residency without having to switch a program. So you can, you know, if you have the capacity in your program to actually take you into IR and give you a year of IR, you can stay in DR and do that, you know, and, you know, there's no reason to change to under another program director to do that. You can still do it and stay in DR if your program is able to do it. Anyways, it's less hassle, less paperwork. And that's what we're going to do. We have already had a VR pathway, so we're going to continue. They're going to continue with their curriculum that way. To change their name from one to another, it doesn't make a huge difference. I know some are, you know, want to do it because of the fellowship. So if they do it, this means they're going to stay. They don't have to go through the match. I'm going to now speak on behalf of ACME. ACME is not encouraging the transfers for the sake of just not to go through the fellowship match. And if that's the only, that should not be the only reason. Transfers should happen, should need a reason for them to happen, and that should be submitted. And that usually is, you know, the gap years, the 2 years makes sense. And if somebody, you know, matched into the transfers the rules were made. So if somebody comes into DR, then they found out that that's not what they want to do. They want to go into IR, and that's the way it should be. So I don't think the HHB is excited to see, you know, several transfers happen routinely at all programs back and forth. There's a lot of financial implications locally at a lot of institutions, each transfer. So some departments may just tell you, no, we're not going to do it because financially this is an issue for us. There's some issues related to what's called salary line, and if a program loses a resident to another residency, they lose a salary line with them, and some things like that it just, the way the salaries are calculated make it harder. So not just the fact that someone who is currently an R3 can just go through the fellowship and would rather just be in the IR residency just to stay at the same institution. It's not as simple as just, I'm going to raise my hand, I'm going to jump from one program to another. There's more involved, and don't be surprised if your chairman, program director, and your GME are not so excited about doing that transfer. So I don't want to put a damper on any of you's plan to just say, I'm just going to go to my program director, tell them I want to transfer. There's more involved in it, and as I said, as you heard, some programs have had it successfully. For example, at Michigan, they have it all figured out. They already had a plan for it, and there are no issues. But it may not be the case at every program that they have that set up already.
Okay, thanks a lot for Dr. Walker, Dr. Sabri, and Dr. Khaja for answering that first question. The question is, what kind of difficulties did you guys experience during the DR to IR transfer, and also a little bit related to like MGH who will have transfers in the near future? What kind of difficulties, Dr. Walker, did you anticipate which may happen during the transfer from the DR to IR transfer process? So this question will be answered in the following order. First, Dr. Sabri, then Dr. Walker, followed by Dr. Khaja. Dr. Sabri, please.
Yeah, I mean, as I said, we have done other transfers, and I mentioned my opinion about the difficulties that you would experience with these transfers. And I think as a program director currently I'm the program director of DR, but I know the program director in IR at our institution. For them, we have to create a new clinical competency committee, the CCC, and all the evaluations that come with it, and filling a lot of paperwork for residency. And the question is, do you really need to do that for one resident or two residents? I think it has to be well thought, and if you want to transfer, it's better to transfer in bulk. Like they did in Michigan, they decided now it's meaningful to have a group of residents. Now you can fill meaningful paperwork, because there's a lot of paperwork done for a residency. So, so that's something that I anticipate a lot of IRPDs may not be as excited about it for some places, and some others may be willing, and the setup is there. But I think paperwork, I think, will be probably the biggest difficulty.
So I fully agree with you, Saher, in terms of not feeling that there's any urgency now to begin to encourage transfers, unless, as at the University of Michigan, this was something that kind of already had a pathway that had been set out. I believe that our institution will do the exact same thing and wait until after this match, and we actually have the first incoming class in 2018 of the R1 to the IR residency before we begin to consider any transfers from the current DR residents. For exactly those same reasons that you just outlined a moment ago, that there's so much involved in getting it right and being certain that we have kind of all of the necessary evaluation tools, and that we have the program well thought out for people who are transferring over. Obviously, that's going to be a necessary thing by 2020 in terms of transfers, but I don't feel that there's any urgency. And again, I don't feel that there's any benefit at this point, just from a nomenclature standpoint, to be able to say I'm an IR resident as opposed to a DR resident at this point.
So, from a program that has converted our residents from the DR to the IR, I would say there were some things. Again, you have to know what the program requirements state, and Saher stated those very clearly, including the RRC, the ABR, and your local GME, as well as having all of your program directors involved. I think the hardest part for us was, as Saher mentioned, getting the PEC, or the Program Evaluation Committee, and the Clinical Competency Committee set up. They are, for the IR residency, more IR focused, but with the involvement of the Diagnostic Radiology faculty and the program directors. It is, for many interventional radiologists who are used to the fellowship, the traditional model, it is a change to be involved with residents from medical school on throughout their residency and to what was previously called the fellowship year. And so I think having multiple interventional radiologists on board with the residency model, I think, would be the biggest challenge. The paperwork, I think, as both Dr. Walker and Dr. Sabri mentioned, is somewhat tedious. I think it is doable. I think the hardest part is the culture change and getting everybody on board and understanding the true process, including the milestones and everything else. I think it's important. I think the reason that we proceeded with this is in order to set up to start that culture change sooner and to give the residents a true identity. So those who have declared that they want to be in a future in IR can set up their relationships with other clinical services as well as a identity sooner. So that's the reason that we sort of moved on with this.
Okay, thanks a lot for answering that question. I think a lot of important aspects have been discussed, particularly also how to what would be an ideal how do the program directors also from the DR standpoint may react, and what are the problems, and that it's obviously key, I guess, to consider transfer well. Our next question relates to a little bit what the key factors are when you as program directors start to select candidates, particularly in a situation when there is more than one candidate. Dr. Sabri was telling earlier when on the first day of your residency, all of a sudden three or four candidates come and they really want to switch. What are the key factors you're considering when evaluating a DR resident for transfer? How much weight will you put in on medical school grades, board scores, and how much of a factor will the ABR and service exam be in evaluating residents for transfer? It would be obviously for residents on a later stage like PGY 3, PGY 4, or 5 who had some ABR scores. What are other factors you're considering, in particularly when you have more interested candidates than spots available? And this question will be answered in the following order: Dr. Khaja, followed by Dr. Sabri, and then Dr. Walker.
So I think this question is a great question, and is one that will be hard for any of us to answer because there hasn't been an established program for this really anywhere, including in Michigan. We had residents who had matched into the VIR clinical pathway, and so they had established that they wanted to be IR residents. I think, though, to answer some of the points, I think what we would be looking for is overall performance on rotations, not just IR, but all of the rotations, because we want to make sure that we're putting out very well-trained radiologists, and not just diagnostic and not just interventional radiologists, but well-trained clinical interventional radiologists who, to be honest, many will not end up in a 100% IR position in the future and will be doing radiology in addition. So we want to make sure that that's true. We want to make sure that the residents have done well on all of their milestones and that are in good standing with the program. In terms of medical school grades and board scores, I think that those matter less because these residents have already been deemed good enough to be in the diagnostic radiology program. And so going back, I think, to medical school, their board scores and personal statements, things like that, really will be of no significant value. And I really don't think that that would put up against each resident in order to evaluate this. And then the final point of the ABR in-service exam, I think there's differences in opinion with the ABR in-service exam across many program directors. I think that we like to see residents improve in the ABR in-service exam, but I don't think it's yet where we can use it to compare. I think that it's extra support for somebody's application to show that they have had continued improvement in all of the subspecialties of radiology, obviously a focus in IR, but I don't think it's something that I would look at specifically. I do think the one thing that would help anybody's transfer from a DR to IR, and if there are multiple candidates, is having involvement in IR, whether that's research, QI projects, being involved with improving your division in some other way, teaching medical students, anything to show that you're really dedicated. And of course, involvement in the resident and fellow section of SIR is a must. Those are things that are going to help you and your potential quote-unquote application to the IR residency.
Thanks, Minhaj. I actually don't have a whole lot to add. I think Minhaj hit on all the important factors. Your performance in IR matters a lot, and the way you treat people and all that stuff. And you just have to look at not just the grades and performance, but all the other aspects, professionalism, and research, presentations. All these things matter. Going back to med school grades and board scores don't matter. Once you show up for residency, all this stuff is less important or not important at all. In-service exam, yeah, I mean, some residencies, it matters more than others. Usually, if it's sometimes it doesn't fit, like the score is low when someone is really good at rotation and someone's the other way around. A lot of times it tends to follow the overall performance. So I think it's one of the parameters, but it's not the only parameter. This thing is going to be more applicable to the ESIR selection more than just the transfers. I mean, I think most of the ones on the, I'm assuming there's a lot of residents here, so they won't care much about ESIR, and the more senior residents, they're thinking about the transfers. But for the more junior, if there are any interns now or any senior students, ESIR is going to matter to them, and same criteria is going to apply for selecting who actually gets to get ESIR. Every program had to submit a criteria of what is their criteria to select ESIR candidates internally, and had to be approved by ACGME, that criteria that they submitted, and many include the items that we just mentioned here. And some want to going to form committees to sometimes interview candidates and such. So there are different ways that programs will do it, but in general, I would say probably the biggest thing is a feel for the resident, and everyone who's been doing residency evaluation for a while will know a good resident, because we've been evaluating residents for the fellowships all along, and we can tell who can be a good fit and not a good fit. So Dr. Walker will, when he worked for somebody, he trained so many residents and fellows over the year, and can tell by just working with them if they're a good fit or not. So let him talk more about that.
Yeah, so I definitely agree with the previous points that were made. I particularly agree with the point about kind of performance in diagnostic radiology. We obviously, as an interventional radiologist, are going to want people who are technically skilled and who are clinically oriented, and as that's kind of one of the driving forces behind why this change has taken place, among many others. But those are certainly some very important parts of why we have embarked on an IR dedicated residency. But that said, the point that many people will enter into practices where diagnostic radiology may play an almost equal role in terms of what their daily workflow is, having a very sound diagnostic radiology platform is very key. And since we really see people only in the IR section and know kind of what their technical aptitude is, et cetera, and don't have anything other than kind of the passing comment that you hear here and there from other subspecialty areas of radiology, I think it's going to be very important for the diagnostic radiology program director to offer us some guidance and some help when considering someone for transfer. We really want very, very strong people, obviously, in the IR residency, but we want them to have this very, very solid foundation. So I think that can't be overstated, kind of this really great groundwork in diagnostic radiology, in addition to kind of great performance on the interventional radiology rotations. I definitely agree about kind of where the medical school grades, board scores, et cetera, fit in. Those, I think, were all kind of screening areas prior to anyone entering into the diagnostic radiology residency. We do like to see improvement on the ABR in-service exam, and of course, there again, that's a reflection to some extent on how people are doing in all subspecialty areas of radiology. So I think that helps a lot. But again, kind of those matters between diagnostic radiology and interventional radiology.
Thanks a lot, Dr. Walker and Dr. Sabri and Dr. Khaja for answering that question and elaborating a little bit on essentially how to select the ideal candidates, and also obviously putting an emphasis on both on the IR side but also on the diagnostic skills. The next question relates to the advantages and a little bit disadvantages of transferring into the IR residency. What is your thought as program directors? What would be a little bit more the advantages? What do you see disadvantages, challenging when transferring? How do you also guide young residents who are not 100% clear on the decision? This question will be answered in the following order: Dr. Sabri, followed by Dr. Walker, and then Dr. Khaja.
Yeah, I mean, I think we alluded to some of that before, but let me, about from the program director's perspective, the disadvantages that we have in doing the transfer. The advantages is probably it's going to be essential in the gap years. So for the current interns and PGY2s, we're going to have to transfer them or have them go through the independent. So I think that is going to be the main advantage. I'm going to talk to the current residents who are thinking about it. You know, there's not going to be a whole lot of advantage to you to transfer if you have the mechanism at your institution to do the same year, which is similar to an ESIR year or a similar to the PGY 5-year in the integrated residency. If you can do it and stay in DR, I think that'll be the easiest thing to do. Just to have the name of I graduated from an IR residency, then DR residency, I don't think there's a whole lot of advantage. You're going to have, you know, have to mention it, and every time you apply that you transferred from one program to another, that you did these many years of this program, this many years in the other program. You know, each department is going to handle their certificates differently. Some are more strict than others. But in general, I don't see a whole lot of advantage. Everyone is going to have to go through the new exam anyway. So now the old exam is gone. Everyone, or the current fellows now, they're going to go through the new exam. So, and they're going to get a certificate of an IR-DR certificate. So you're grandfathered in. So if you're a current, you know, R3, I don't see a whole lot of advantage, and R2 or an R3, I don't see a whole lot of advantages to transfer if you have that mechanism. Now, if you don't, and you think your only way to get the extra training in IR in your the 4th year of radiology is to go through an IR residency, depending on your local politics and things like that, then I think there's an advantage to do it, because that extra time of training will be very beneficial to you. Again, about skipping the fellowship and not have to go and you guarantee a spot, I just don't encourage it personally. I think someone may think it's an advantage to stay, but that can still be done locally through the fellowship match and not have to go through the transfer to do that.
Yeah, I completely agree. I've actually had this issue raised by some of the residents at Mass General who are interested in IR, wondering, should I do this transfer? Should I just, again, as you said, Saher, the R2s and the R3s, where we have this internal program that so many other institutions actually have, kind of mimicking the ESIR. Actually, what we're doing is for R2s, R3s who kind of declare early on that I anticipate doing the IR fellowship. Of course, while that training pathway is still available, we actually try to put together a 24-month curriculum between the R4 and what would be the fellowship year, so that we look at it as a 24-month block and actually arrange all of those various things, such as vascular surgery, the ICU, other IR-related rotations, as a vein clinic, for example, and imaging time, et cetera, but individualizing that actually for the various residents, so that if someone has, for example, a really keen interest in neurointerventions, we are able to kind of give them that as an option within the 24-month period. If someone else has a really keen interest in some other type of IR-related rotation, we can do that, so that we're tailoring and individualizing those for each of the residents between the R4 and the fellowship year. So until we get to that 2020 and 2021 kind of time for transfer, I also don't see great advantages. I think that we can handle that with the current arrangement. And again, I think it's just semantics, but I don't think that semantics matter at this point.
So I think I agree in terms of the complexities of the transfer, as well as some of the semantics that Dr. Walker mentioned about it. But I do think that there is some benefit into the increased clinical education that is part of the IR residency. and establishing it formally has some benefits. As Dr. Walker mentioned, sometimes you can form these relationships and these rotations on an individual basis within programs, but I think formalizing it makes it somewhat easier for the programs that you're working with to understand that, such as vascular surgery and the ICUs, to know that there's this IR residency, there is this curriculum, and our residents there are residents from other services who are a part of it. The other part that we found very important is, and we'll see, is establishing relationships within the department and other services, and establishing an identity for the residents themselves. And so that really helps, I think, our residents sort of feel part of a new program, developing program that is their future career. And so I think that is the advantage of it. The disadvantages are, of course, there is a lot of tedious paperwork in the transfers, and there's sort of a state of unknowing. And so I think unless you're very sure and dedicated that you want to do it, that I would say you should find a situation that fits you with either ESIR at that program or the traditional pathway and traditional pathway in converting into the independent.
Thanks a lot for answering that question. Now the audience can start submitting questions. Please type your question in the provided chat box. The questions will be visible to the moderators. When asking the questions via the chat box, please indicate if you would like to direct a question towards one specific program director or to the whole group. And while we're waiting for this audience submitted questions, the final question we've prepared for tonight is, do you guys have any additional recommendations for junior residents who are interested in transferring to the integrated IR residency? Any thoughts, anything you feel we haven't covered, any insights? And this question will be answered in the following order: Dr. Walker, followed by Dr. Khaja, and then Dr. Sabri. Dr. Walker?
Oh, yeah, well, I do think we've covered quite a lot of this in terms of kind of the pros and cons, and in terms of kind of what to look for in terms of your certainty about whether or not this is exactly what you want to do. I had mentioned that one of the reasons we have not yet had any transfers is because, of course, we're still within, at least my institution, we're still working within a training complement who originally matched to be diagnostic radiology residents. And quite honestly, unlike some programs who have a direct pathway, many of our residents are kind of still in that phase where they're really trying to feel their way into, which subspecialty I'm actually interested in, within all the various subspecialty areas of radiology. And so I guess, one of the things, if someone is in that sort of a situation where they entered diagnostic radiology, uncertain as to whether or not interventional radiology was the subspecialty area for them, is to really throw oneself into the IR rotation, to see all aspects of it from the standpoint of clinical longitudinal care, procedural care, the imaging components of it, and just be certain that a transfer is actually in your best interest. Now, for those obviously who have entered with the idea that the diagnostic radiology residency is perhaps a vehicle for interventional radiology, then I think it's much more clear-cut. It's just kind of the timing of the transfer. Is it even necessary before we get into the later years? I do completely agree with Minhaj that there are benefits from establishing the IR residency and making the institution and the various other training programs really aware of that coming. We've really done quite a lot of groundwork in that regard with the various other services. So indeed, as was said, we have gone to vascular surgery, although that's already a standing rotation for all of our fellows. We've gone to them, letting them know that this is going to be a continuation, but in a different pathway. We've done the same thing with the ICU. We've done the same thing with the internship in terms of being able to offer that. So from an institutional standpoint, I think everyone's well aware of it, and I think that's a very important point. And now I think it's just, at least at my institution, we won't be encouraging transfers for transfer's sake alone.
Minhaj, do you have, I think you're next, or I can go.
Oh, sorry. I was muted. I agree. I think that, you know, it's important to know what you want and to be involved. And if you're involved with radiology and IR, if you know it's something that you want to do, it's something that you should pursue. But I would not transfer without really knowing that that's your future. And you may not have that as an option at your program. I would definitely talk to your program director if it's something you're interested in and get some more information. And from there, you can decide if this is the right thing for you or if you should just continue in your current pathway and join in the independent pathway.
Yeah, I mean, I think it's the same. I think it's going to be different for the current senior residents, the R3s and R2s. As I said, there's not a whole lot of advantage unless you cannot get that year that you need, unless you transfer. If that's the case, then I think it's good to transfer. I know, as was mentioned before, build a good relationship with the IR department from the get-go, whether it's research and involvement in general. Now, for the R1s currently who just started, I don't know if there are any interns on, when you show up next year, sometimes you may not get to IR till late. So I think show interest early, see if there's any meetings, research meetings, try to kind of get involved in journal clubs and that, and show early interest if you can. When you get presented with the option to transfer in your second year, you have to be sure that that's the career that you want. Most of the time that's the case. In your third, you have to commit to a fellowship. So sometimes we have to decide in this transfer process, you may have to decide a year earlier because many others in your class may already have made their decision. So it puts some undue burden. We've had many cases, all three of us can tell you of cases of when a resident is interested in IR and after the first and second rotation they change their mind, end up liking something else they don't get the chance to get exposed to till a later year. So that's something that is going to happen. So you have to be really sure that that's what you want. And I know that's the premise of the IR residency, is to get people committed even for the med school. But sometimes after you have more options in the residency, you may change your mind through it. So just be sure that that's what you want and commit to it. And I think if that's what you want, IR is what you decided on, and you're a current intern, a current R1, and get presented an opportunity to transfer to fill these gap years, I would go for it. I think it's a great way to train, and will give you opportunity to have some the sense of identity, as Minhaj mentioned, and then longitudinal care that allows you to see patients more frequently and be more involved in the IR clinic and such. So I think it's a great way to train, and it's going to be not transfer for the sake of transfer. It's going to be a transfer for a needed time. I think it's good to start it at that time.
Okay, Dr. Walker, Dr. Khaja, Dr. Sabri, thanks a lot for answering all the questions for tonight we've had so far, and now we're going to open essentially the questions to the audience, and Akil will give the word to Akil, who will take over and who will introduce some of those questions to the program directors. Akil?
Great. And thank you again to the panel member attendings for taking the time to do this for everybody. I think we've gone over a lot of good information. So we're getting a lot of good submitted questions here, and a lot of them have been covered based on the various presentations and frequently asked questions so far. So we're going to focus on questions that are related to our topic, switching from DR to IR. And if there's anything that is still pressing afterwards, we'll have our contact information available. Please do not hesitate to get in touch with us. We'll be happy to direct you towards whatever information you're looking for. So the first question, this is going to be directed to all panel members, is do you see any benefit to the independent pathway versus the integrated pathway? The rationale being you're getting 2 years of dedicated IR training kind of consistently back to back versus IR training kind of spread out and IR related rotations not necessarily condensed into a 2-year focused training program with the integrated pathway. and also vice versa. Do you see any downside to the independent pathway? And we can start with Dr. Khaja, followed by Dr. Walker, followed by Dr. Sabri.
So I think my answer to this question would be sort of somewhat biased. I went to UVA for the clinical pathway, and what I liked about that is the integrated component of it. I think it's really important to have components of diagnostic radiology, clinical medicine, and interventional radiology throughout your residency, so you kind of are on top of your game with all sides of it at the same time or at all times. So I think that that's very good for you as a physician, and to sort of reinforce what you learn on the diagnostic side with procedural medicine as well as clinical care of these patients in a longitudinal fashion. I think that there is a lot that you can learn in that last 2 years, and if you do all of those clinical rotations, you will also benefit from that. So I'm a little biased, but I think that they're both good options, and that RRC has definitely, and SIR has thought about it, and they both have their benefits to them.
Yeah, I agree. I think they're both very good options. I also do agree that kind of the way the integrated pathway is set up is kind of the more optimal sort of arrangement, in that we really have kind of these 5 dedicated years to structure within the ACGME guidelines and the RRC guidelines, kind of a training pathway that will hopefully kind of ramp up year by year by year to kind of culminate in those last 2 years, which will be so IR heavy. And so I think that's kind of the ideal pathway. Not to say that the independent pathway is going to be lagging drastically behind the other. I mean, one of the things about the independent pathway, as we've thought about it for our training complement at Mass General, is that we believe, based on kind of this overwhelming response that we've seen in terms of the numbers of applicants for the 2018 positions, that we may have less actual capacity in the integrated programs than the numbers of people who would like to become interventional radiologists. And so for that, considering, again, my own institution where we plan to have, pending approval, 2 independent positions, internally that gives us an option for people who came into the diagnostic radiology residency and realized fairly quickly that they like interventional radiology and would like to fill those other 2 positions in our institution. Then we would do everything we could to kind of mirror once again what we're doing for curriculum in the integrated program. But then the converse is true. If for some reason there are some years in the future when perhaps IR, and I hope this is not the case, might be somewhat less popular in a particular class, we do have the option then for people who are in a diagnostic radiology residency that doesn't have an interventional radiology residency to allow positions for people to come in from other programs. So, so I think each one kind of has options, and that's kind of how I view it at this point.
Yeah, I totally agree, and I think if you have the chance to go through an integrated program, it's just easier to do it that way. And no, it just depends. We're talking to students applying. So if you're applying, if you think IR is what you need to, is what your goal is. To go into an integrated program is easier. It's a more optimal program. The issue is there are not enough spots. So there's always a risk of changing your mind later. So these are the 2 issues of the integrated. So I would say if you're not sure that IR is what you need to is what you want to do, and you're not set on it, then go through DR and go through the independent, and you'll still get great training. The downside of it is you don't know if you're getting if you're going to finish in 6 years or 7 years, depending if you're going to get ESIR or not. You're going to show up at a place and there's 5 people who want to do ESIR, and the program can only do 2 or 3, so you may end up being left out. So, you know, that's one of these issues. While if you go through integrated, you're set, you know exactly where you're going, and everything's clear. So, if you're already a resident, it's a different story. If you are a first-year resident now or an intern, would you transfer into integrated or stay for independent? Again, if you figure it out that that's what the IR is what you're interested in, transfer. If you're not, you have to wait till your third year and then enter the match for the independent. And both options are fine as long as when you enter the residency, the training is going to be very similar, ESR independent versus integrated.
All right, great, thank you. So the next question, just kind of a common theme we're seeing in these submitted questions right now, is based on getting a sense of how competitive and how many spots will actually be available for the independent pathway. So I'll read one audience member's questions to kind of give a framework, and then we'll have all panelists give their input on this. So for the class that is graduating 2020 from a diagnostic residency that knows they want to do IR, but their institution does not offer an integrated IR residency, what is the likelihood of enough spots being available for the 2-year IR fellowship, for the independent pathway, essentially? So if the panel members, I think, kind of to answer this question, can give what their thoughts are, if they have kind of a good maybe analogy or comparison to how competitive they think these independent spots will be for folks. Is it something that will mirror the similar fellowship application with the traditional pathway now? Is it going to be something completely different competitive level, or is it just too early to tell at this point? And we'll do the order of Dr. Sabri, followed by Dr. Walker, followed by Dr. Khaja.
This is an excellent question, and I wish we know. We don't know the answer. As Dr. Walker mentioned, there are currently no approved independent programs because the application cycle just started. So the first programs just started applying now, and it's going to be a 2-year process before we have the full number of how many integrated spots we have. We know we have around 120 or so integrated spots currently, which most likely they're going to go up with time. And we have, probably, 2.5 times the applicant number to that. So it's pretty competitive. So we know there's going to be a good number of residents who are going to go into diagnostic radiology who are not in the independent, and we're thinking that number is going to be substantial. Will there be enough independent? We are encouraging everybody to apply for independent as well as integrated. We think this is just a guess. I know this is recorded and someone's going to bring it to me, several years from now. But my guess is we're going to end up with the same number of graduates when it's all said and done to what we currently have. Is my guess, which is in the mid 200s. So I think eventually the overwhelming majority of current students who are interested in going on or first year or interns thinking of going into interventional radiology will find a spot, because there's usually people changing their mind down the road. So no one can give you a full answer of how many independent spots are going to be, but and that's why it's something that we're encouraging all programs to apply.
Yeah, I agree. I do think it's a big unknown at the moment. I do definitely feel, based on the overwhelming numbers of applicants we're seeing this year for a somewhat limited, because of course there are somewhat limited number of integrated positions. As Saher said, I mean, we still have institutions that are applying, and we think those numbers will go up. But based on the huge number of applicants for 120 or so spots, and I think there are double to almost triple the numbers of applicants for those spots, many institutions are encouraging applicants to apply both to DR and IR. And I think kind of the unspoken message there is that if you don't secure an integrated position, that perhaps your transfers into the independent position, one might be able to eventually come into an IR position as a trainee. So a worry I would have is, and again, we don't know the numbers, but a worry I would have is that there's so many people, even in this initial round, that are trying to enter IR, and their fallback position is to go into DR with the idea of transferring. It may be in the short term, until we have more and more independent positions available, that independent positions will be kind of a bit desirable, and perhaps kind of not as many of them as we would hope to have.
And I don't have much to add to that. I think Dr. Sabri, as being a member of the RRC who has been evaluating these early applications for the independent pathway, has a better sense of the numbers, and I don't think anyone has a great sense of the numbers. And so for those residents who are currently in programs, I think it's something to keep up to date on, and I think SIR and the RRC will continue to provide information about programs who are as part of the independent pathway, and I can't imagine though that there will be a huge number of positions for that final year.
All right, thank you. This question was asked specifically for Dr. Sabri, so I'll direct this towards you, Dr. Sabri. It says, Dr. Sabri, can you comment on your clinical integration and IR rotations your first 3 years, meaning PGY 2, 3, and 4, and compare and contrast to the integrated IR residency, which suggests only 3 months of IR, 1 each year in the PGY 2, 3, and 4 years, and ICU month in your PGY 5 year?
Yeah, I mean, we've had a VR pathway since 2002, and that pathway in the past had what was just mentioned. That's the pathway that Minhaj went through it, and he has front row seat that he can speak more about it. And basically it just has more integration of some of these IR-related rotations, is what we call them now. Early in the process, in the second year, do some ICU early on, and do some vascular surgery early on, and do some clinic throughout the 4 years. So the idea is to stay involved in clinical rotations, and not just in the last years. Now, when the integrated IR residency program requirements were written and evaluated, many of us who went through this, encouraged to have that leeway in the program requirements to allow these rotations to happen earlier, and that was granted. But it's not easy for every program to do it, because many DR programs are not willing to give up that much time for the residents to spend time away from DR rotations in the first 3 years. So it was going to be a compromise, and every program is going to look at it differently of what their curriculum is going to be. But there's a lot of leeway in the program requirements, which was great to see. In the ICU rotation, it's something that is it should occur in the last year, and if you do it early on, it should be done also in the last year. That may change down the road, but that's the way the program requirements are now, and that's the message that was sent from the ACGME. But in general, I have the feeling that this is better to be involved in clinical rotations throughout, not just doing them later on. But that's the model that is in the integrated residency, but that doesn't mean that it's not allowed to do some other rotations earlier on.
All right, great, thank you.
So if I don't mind just answering that from somebody who went through that through the residence, as sort of a residence perspective, is I think that it was really important to continue to have basically reminders of this clinical care, whether it is on an IR rotation or an ICU month or a clinical rotation with hepatology or vascular surgery. It keeps you on the top of your game. And so I think that having that ability is really useful to you as a resident, and it really provides a benefit to the department as a whole, because you are the face of radiology on these clinical services. And so having that ability to have these integrated rotations will be really beneficial to everybody. I think the residents, the referring services, the patients, and the department. And so I think it's really important to continue that. And in terms of having ICU, that was one question when we applied for that IR residency. We thought it would be good to have that early on. The RRC recommended that it should be during PGY 5. And so I think we decided to do it during PGY 2 and PGY 5 because it's very good exposure, and it's early on while you have just finished your clinical experience, and then a refresher course to take care of critically ill patients when you're on IR.
All right, thank you. So the next question is going to be for the panel, and this question reads, as the last class with the fellowship available, do you believe less fellowship spots will be available for the class of 2019? If yes, then do you feel it would be beneficial to transfer to an institution with a fellowship or residency if a spot became available? So essentially the question is asking for folks that are going to be kind of at the tail end of the traditional pathway who will be graduating and applying for fellowship in 2019, do you feel like there will be less fellowship spots available? And is there any benefit to going, if their program does not have a fellowship spot, getting into a program that does have a fellowship spot at this point? So we'll go Dr. Khaja, followed by Dr. Walker, followed by Dr. Sabri.
Sorry, so I was muted. I think that Saher would be able to mention that right now you cannot have a resident transfer from a DR program into an IR from a different institution. And so I don't think that that is actually an option, at least for the integrated program. And once people have been approved for the independent pathway, it would still be 2 years at the end and you would be applying. So I don't think that that's an option as of right now. I'd prefer to Saher to clarify that.
Yeah, I mean, it's not an option, and one of the, if I understand the question correctly, there was a talk about maybe going to a another DR to another DR program, and then later internal transfer. I think that's playing with the role. So now you're not allowed to go to another integrated program. The question is, do you think the fellowship numbers will be affected? I don't think so. I mean, some may have some internal transfers, which means they're going to fill internally. But usually, if they're going to have the same effect for programs that currently through the fellowship match, they fill internally already. So it's going to have the similar effect. I don't think it's going to have, practically a less available number for you to apply to. So it may be a minimal change, but I don't think it's going to be an issue. So I would not worry that much about it. I would think to improve your chances of getting the fellowship you need is to get as much IR experience and see if there's a way to get in your last year these mini fellowships or you focus time in IR and any procedural rotation to kind of get you ready and do research in IR and all these things. And if you make your application better and stronger, I think you'll be fine securing a fellowship.
Yeah, I agree. We have at NGH one of the larger fellowship programs in the United States. We had 9 fellows, and if we decrease for that last year, it might be by 1 fellowship position. So I think it'll be a minimal change in terms of the numbers of fellowship positions available. I don't think you're going to see substantial number changes.
All right, great, thank you. So we have time for one more question, and this will be directed towards the entire panel as well. So how do you think current fourth-year medical students who are interviewing for diagnostic radiology at your programs will be viewed if they voice an interest in potentially transferring into IR at a later time? And we'll have the order of Dr. Walker, followed by Dr. Khaja, followed by Dr. Sabri.
I'm sorry, would you just repeat one more time, please?
Sure. How do you think current fourth-year medical students who are interviewing for diagnostic radiology at your programs will be viewed if they voice an interest in potentially transferring into IR at a later time?
So I don't think I think they'll be viewed positively. At my particular institution, the diagnostic radiology faculty is actually recognizes the tremendous interest in interventional radiology, and in fact many have felt that there's a kind of net benefit to diagnostic radiology as a result of the kind of resurgence, the very much interest in the IR residency, and how that is actually popularizing to some extent the diagnostic radiology residency, where there have been some falling numbers in the past. So I think that they'll be welcomed from the diagnostic radiology standpoint, and I also, from the interventional radiology standpoint, feel that people who express interest early on are going to be people that we will try to encourage to look at interventional radiology very carefully, to consider whether or not this would be something they would continue a pathway whereby they might transfer internally. So I see it as a positive.
I think it would also be important for those medical students to ask the programs to which they're applying whether they're going to or plan on submitting an application for the independent residency as well as ESIR. You know, not everyone has submitted their ESIR application or been approved, but most of the programs who have an integrated residency will be submitting for that, and hopefully will meet the requirements. And so asking that question, I think, will be not at all harmful to their DR application. If the program has an IR residency, I would consider, if that's something that you're interested in, to interview for that as well. But again, you should be sure that that's what you want to do. And I think another key component of this all working is that the DR program and the IR program should be really integrated, not just when you're integrated in your clinical training, but also just in your ideology of the importance of the IR residency and the importance of DR to it. And so having program directors on both sides, the chair and faculty who agree with this, having support from all sides is extremely important. And so if you hear from somebody on the DR side that, well, if you get that sense, then maybe that's not the right place for you.
Yeah, I mean, I think as a fourth-year medical student, you can apply now. So if you apply to a program that has an integrated residency, if they fill their positions, you're unlikely to transfer into integrated. So what you're going to be doing, if you mention to DR, is you're going to be applying for ESIR, that independent, which is like, so I think it's important to voice that interest, because most likely you also apply to IR integrated at that same place. So now if you apply to a place that does not have integrated, and they potentially could have integrated, of course, you should let them know that. I think it's a positive to say that I'm interested in IR, and if you establish integrated, I would like to transfer there. And for any program that has ESIR, or which there are 40, some of them they're already listed, and there's some unupdated list from last week that you can find on the SIR website. Or even if they don't have ESIR, ask them about it. Are you going to have it? Because I have an interest in IR, and they do it. You just need to know that maybe 2/3 or so of the applicants to the IR integrated are not going to end up in IR integrated. They may end up going into a DR program. So you just need to make sure that that DR program has the tools to allow you to get trained in IR. Do they have ESIR? Are they planning of having ESIR? Are they applying for independent or not? And to voice that interest early on, I think that's important and that's positive. It's no different than anybody coming and say, I'm interested in MSK or breast imaging and such. I think it's not something you should hide. You should be very, very clear that where your interests lie. I think it's been viewed positively, and we've seen a lot of great applicants, and as Dr. Walker mentioned, a lot of the DR colleagues are seeing the excellent applicants who are interested in IR, and I think that's been positive.
Okay, great. So that's going to be the end of our audience submitted questions portion, and like I mentioned earlier, we'll have our contact information available. If there's any questions that weren't answered, please just direct them towards us, and we'd be happy to get you that information. And I will pass it back to Sasan at this point.
Thanks a lot. I want to say a big thank you to our 3 program directors who took the time tonight, who were able to attend, answer a lot of questions. I think we covered a very broad range of topics. Again, thanks so much for attending. And I think on the last slide, you guys see also our email address. If you want us to contact us, if you have any further questions, feel free to send us an email. And again, thanks so much for attending the webinar, and thanks so much for Alex, Akil, and Andy for all the terrific efforts and support. Yeah. Thanks a lot.
Thank you.
Yeah, thanks very much.
Thanks, everyone. Bye.
Thanks, everyone. Have a good night.
Thank you, everybody.